Hello, welcome to today's webinar hosted by the Association of Food and Drug Officials. My name is Jerry Voitala, and I'm the Executive Director of IFPTI. Thanks for joining us today. Today's webinar will highlight some of the IFPTI Fellowship in Food Protection Cohort 9 Fellows as they present their research projects. This is the first of 3 installments of presentations, so be sure to mark your calendars for the other 2. These presentations are the culmination of a unique year-long leadership program funded under a cooperative agreement by the FDA Office of Training, Education, and Development and by AFTO. Today, we will experience 4 project presentations. As for the format, the fellows have been given strict requirements to consolidate the presentation of their project into a 10-minute segment, followed by questions from the audience. So if you would like to ask questions while the fellow is presenting, go to the bottom of your Zoom screen and type your question in the Q&A box. We may not get to all your questions in the interest of time, but if that happens, feel free to contact the fellow by email or contact IFPTI and we'll put you in contact with the fellow to learn more about their projects. So with that, we're going to get right into it. So let's begin. Nick, would you like to start us off and introduce yourself?
Sure, I can start us off. Let me just share my screen really quickly.
Okay.
One second. Okay, so hi everybody. Hello, and thank you for joining me in this presentation for IFPTI Fellowship in Food Protection. My name is Nicholas Alviani, and I am a registered environmental health specialist with Lane County Environmental Health Department in Oregon. I am also a fellow in Cohort 9 with IFPTI. Good morning. Well, actually afternoon for all of you. Today, I will be discussing the functionality of environmental health and incident command system in Oregon. I will talk through information I collected on the use of environmental health programs in emergencies in Oregon. Oregon has 36 counties. Most have dedicated health departments with environmental health programs. Some have contracts with Oregon Health Authority or adjacent counties. Environmental health programs consist of registered environmental health specialists, now to be referred to as EH, who regulate food, pool, lodging, drinking water, and septic facilities in Oregon. Now I will discuss the Incident Command System. Incident Command System, now to be referred to as ICS, is used throughout the United States. It was first developed in the 1970s in California in response to wildfires. Now, this system is used to organize emergency response incidences. ICS is broken up into 15 emergency support functions, now to be referred to as ESF. Each can be utilized depending on the type of emergency. The visual on the screen shows the branches of Incident Command System. In addition, here are some examples of ESFs. Environmental health programs are commonly utilized in the following emergency support functions: ESF 6 and ESF 8. ESF 6 provides emergency assistance to temporary shelters. ESF 8 includes health surveillance, food safety, vector control, and guidance on potable water. Environmental health staff can contribute to each of these functions through shelter inspections, food safety guidance, drinking water standards, and operations, as well as waste collection and removal. At this point, we understand the use of ICS, but we do not know how EH is used in Oregon. The extent to which environmental health programs in counties with dedicated health departments are utilized in Incident Command System in Oregon currently is unknown. Next, I will present research questions for this project. What percentage of counties in Oregon with dedicated health departments activated Incident Command System? What percentage of counties with dedicated health departments utilize the environmental health programs in Incident Command System? What emergency support functions were provided by environmental health programs with which activated ICS? What are the contributions made by environmental health programs that were utilized in ICS? And if environmental health was not utilized during ICS activation, why were they not utilized? In addition to these questions, I use the following methods to collect information. First, data and information from the following agencies were used. OHA, Oregon Health Authority, provided guidance on environmental health roles in ICS and ESF roles in Oregon. OEM, Oregon Emergency Management, provided public data related to Oregon's use of ICS, including state and county emergency data. FEMA, Federal Emergency Management Agency, which was a source of emergency declarations over a allotted time period, but this, however, did not provide all the data needed. To properly collect data and information directly, I developed a simple questionnaire. This questionnaire calls attention to the use of ICS, ESF, and emergency response in Oregon. There was an option for participants to be interviewed for the research paper. This was conducted to gather more qualitative data in the form of firsthand experience working with and use in ESF roles. In total, there were questionnaires sent out to 28 environmental health programs, as well as 36 counties and 9 tribal emergency management offices. That picture is of B. The main study population are local health departments in Oregon with dedicated environmental health programs, which have activated incident command system between 2014 and 2018, specifically environmental health supervisors. Separately, county and tribal nations emergency managers' offices were contacted and provided the questionnaire. Now that I've told you about the process of collecting the data, let me show you what results have been determined. 9 out of 28 environmental health supervisors, or 32%, responded to the questionnaire, while 1 out of 36 county emergency management office representatives responded, or 2%. First off, Figure 1 shows 50% of responding programs had their health departments activated ICS during the years 2014 to 2018. Figure 2 shows that 2017 saw the greatest number of ICS activation by health departments due to multiple wildfire and winter-related emergencies. Secondly, Figure 3 shows the rate at which was utilized in ICS during 2014 to 2018. Was utilized ICS response 50% of the time. Figure 4 shows total program usage per year among responding programs. The years 2014, 2015, and 2017 were those during which county health departments most frequently activated ICS. When relating the data for usage to ICS activation during the years 2014 to 2018, programs were utilized 12 of 14 ICS activations, or 85% of the activations. Additionally, interviews were conducted with supervisors and emergency managers who responded to the survey and agreed to do an interview. 5 interviews were conducted in supervisors, while 1 interview was conducted with an emergency manager. The interviews included questions about how was utilized or not. Most common terms for how programs were included: food safety, outbreak control, training, facility help, water quality, winter storm response, and wildfire response. Some of the most notable reasons why programs were not used were emergency operation centers may not understand knowledge or training related to emergency response. may not be needed for specific ICS activation. Some agencies had little institutional memory of ICS activation, and some administrations had differing views on whether or not to activate ICS. This brings me to my conclusion. ICS in health departments was activated each year in Oregon between 2014 and 2018. programs were used about 85% of the time. programs primarily supported functions for ESF 6 and ESF 8, which include drinking water, food safety, and shelter inspections related to wildfires and winter storm events. Environmental health utilization was generally related to the nature of the emergency. If the emergency did not require ESF 6 or ESF 8, then environmental health programs would not be used. Separately, some notable factors that may have contributed to the low response rate and limited data pool were the COVID-19 pandemic response and unprecedented wildfires, which severely affected multiple counties in Oregon and overwhelmed local public health departments and emergency management offices. With this conclusion, I have the following recommendations. OHA and incident command staff should use historical information to consider EH usage for future emergencies. Historical information could include EH usage in the state, usage by county, environmental health education and training related to specific emergency responses, and national responses by environmental health specialists. Additionally, EH specialists should advocate for their roles in ESF 6 and ESF 8 in ICS when activated prior to future emergencies. Methods for advocating could include more incident command system training, conducting emergency preparedness exercises with other entities, and continual engagement during any coordinated efforts. These methods could result in better trained staff, better response performance and timing, and increased contact and/or communication management in emergency operations centers. Collaboration between counties, the state of Oregon, emergency managers, and environmental health specialists and supervisors in Oregon was essential to the findings and results of this article, and I thank you all. To my fellows in Cohort 9 with IFPTI who helped and encouraged throughout this process, thank you. Thank you to my mentor, Kathy Fetter, and other mentors with the IFPTI Fellowship Program for your support and expertise. And thank you to my family who also supported me. Now, time for the audience.
Okay, well, thank you very much, Nick. So audience, remember, if you have any questions at all for Nick, please go ahead and open up your Q&A box and type some questions in there, and we'll be able to relate those questions to Nick. And I do see some already. So Nick, here's a question for you. What kinds of emergencies have occurred in Oregon after your study was conducted?
So my study mostly focused on the time range between the 2014 and 2018. The reason is because we started the project in 2019, and that data wasn't yet put out, or at the end of 2019, and that data wasn't fully put out by any of those agencies yet. And so I thought it would be easier to start with the original time frame. But since then, there have been several large events. COVID-19 has been the biggest one, and that was actually part of some of the responses, but I could not add it in there because it wasn't within the time range. And then, like I talked about earlier, there was large wildfires in our county as well as surrounding counties in Oregon that completely devastated thousands of acres of land and destroyed some towns. And it really put a big weight onto local health departments. And since most of them do water operations or food safety or shelter management, those are type of events that occurred afterwards that included environmental health.
Okay, great. Another question for you, Nick. It says, in the case of something like a power outage impacting food establishments, do you know which emergency support function that would fall under?
So when we talk about emergency support functions, we usually put them into functions because of the subset, and it allows people to have a hierarchy of who to respond to. When we have power outages, sometimes ICS will be deployed and sometimes it won't. And they could be put under specific functions due to that. So with power outages, it would probably more of like the health and safety ESF 8, because that way you could provide drinking water and food safety information, and less of the shelter management, because that probably wouldn't be totally affected in every power outage.
Okay. And it looks like we have some questions also coming in on chat, so I'm going to open that as well. So here's a question for you, Nick. Great presentation, by the way. What policy recommendations would you suggest to accommodate your findings?
I think one of the policies that I think could be pushed forward individually per program would be a quota for trainings. Minimally asking programs to have a limited or a minimal amount of training that's required for ICS. Usually it's you have the ICS 101 and 30. Oh no, that's CD. The individual ICS courses that Oregon actually requires is still there, but more in-depth ICS training and more specific towards the programs would probably be the policy that I would recommend.
Okay, and I see another question. Do you know if local health departments consistently have a seat on county emergency operations centers?
So the way that the ICS is structured is they have they have a main agency that can hierarchically oversee the entire sub function or emergency support function. And then you have supporting agencies. And so in general, H&HS, or Health and Human Services, which is the department that houses most environmental health programs, is either a supporting agency or is the main contact in those supporting functions. So because we're a program underneath that department, we may or may not have a seat there, but there will be someone in the department itself that always has a seat at those command stations.
Okay, I think that's the last question I see, except there is a question here that's not for you, Nick, but in general, we'll mention this again at the end, but yeah, this webinar is being recorded, and we will have the recordings up of the fellows' presentations, both on the, I believe, on the AFTA website as well as on the IFPTI website. And you can go to the IFPTI website now and see the fellows' papers and their that describe their projects. So you can see that now. But then, yeah, we'll, after this is completed, we'll get by next week we'll have all the recordings up. Oh, it looks like Nick, you didn't skirt out of this. There's one more question here. One of the problems with ICS training is that inspectors may take the training and then not use it for months or years. How would you address this?
Well, I think continual training is always the best idea for that. And it's not just ICS training that I recommended. It was also participating in different types of events that may or may not be real life events, kind of like trainings in the regards of real life, but more of a simulation. Those are not the general trainings that are required to start up for environmental health specialists, but they're ongoing ones, and they also continue to help with coordinating efforts when you are in those emergencies, because you can contact those facilities. Usually it's with the fire department and the police and other emergency operations that are in general response. But when you start coordinating more and more with those, you do the training more often, you understand the roles, you understand the hierarchy, and you have those contacts with those individuals. And I think that's really the most progressive way of moving towards this, is continuing those partnerships. Training is really important, but you're right, those original trainings, we don't use them right afterwards and we start forgetting that stuff. So continuing that training in different manners besides just the general FEMA training, I think is going to be the best option for that.
Okay, well, thanks a lot, Nick. Thank you very much for your presentation today. If you can unshare the screen, we'll go on to our next fellow. Okay, and Sharia, you're up next. So whenever you're ready, go ahead and take control. Okay, now take yourself off mute, Sharia. Thank you.
Well, good afternoon, everyone. I am Sharia Hudson, and I work with Cobb and Douglas Public Health. And today I will be presenting my research project regarding norovirus risk factors influencing food safety training among certified nursing assistants in Georgia District 3-1 long-term care facilities. So first, let's begin with a little background information. So norovirus is highly contagious with a low infectious dose. In other words, this means that it only takes a few particles to become infected. In fact, ingesting few as 5 to 100 viral particles can cause an illness. Because norovirus is highly contagious, it can easily be transmitted in close quarters, such as correctional facilities, hospitals, cruise ships, nursing homes, or long-term care facilities. It can also be transmitted easily from hands to food through bare hand contact with ready-to-eat foods or via sick or infected employees working with food while they're ill. As far as the incubation period for norovirus is typically short, and one may experience symptoms within 24 to 72 hours after initial exposure to viral particles. In 2018, the CDC estimated that norovirus contributed to 5,461,731 infections. And then within the same year, it accounted for 38% of foodborne illnesses in Georgia. So next, let's discuss how norovirus impacted District 3-1's long-term care facilities. So locally, there were 54 long-term care facilities located in Cobb County, and 7 long-term care facilities were in Douglas County, which makes up District 3-1. From 2016 to 2018, the district experienced at least a total of 11 norovirus outbreaks. And out of those 11 norovirus outbreaks, 7 were laboratory confirmed positive cases. In 2016, there were 2 outbreaks that occurred within the same facility. So that was a concern that we had during 2016. Next, we will discuss the role that certified nursing assistants play in long-term care facilities. So certified nursing assistants, they play a vital role in the care of residents and long-term care facilities. They are basically responsible for assisting residents in their daily activities, such as bathing, cleaning, hydration, feeding, and any other tasks that they may need assistance in. They also receive on-the-job training, and during their certification program, they are trained on basic nursing skills, personal care skills, mental health and social services needs, and residents' rights. However, food safety is not mentioned as a component in their training curriculum, which brings us to the problem statement. Although certified nursing assistants receive some on-the-job training, their level of training regarding food safety practices or concerning the 5 major risk factors that contribute to foodborne illnesses is not known. So next, let's discuss the 4 research questions. How are certified nursing assistants trained regarding food safety practices? What subjects or topics related to food safety are covered during the training of certified nursing assistants? What kind of food safety training is required for certified nursing assistants? And then lastly, how often is the curriculum updated to reflect the current standards? Now for the methodology. So electronic surveys via SurveyMonkey were utilized to collect data from the certified nursing assistants regarding their food safety training. We actually had some EHS who were basically responsible for collecting contact information. And these EHS, they were standardized during this process, and they were provided with a telephone and an email prompt to collect the certified nursing assistants' contact information from their place of employment. And then an interview was conducted via email with the Georgia Medical Care Foundation. For the study population, it consisted of surveying 86 certified nursing assistants from District 3-1's 54 long-term care facilities. So for the results, 14 volunteers participated in the survey. They were asked questions regarding their food safety training while employed at the long-term care facilities and regarding their 5 risk factors that they were trained on. 64% of the respondents stated that no food safety training was provided. 33% stated that they were trained orally regarding their food safety while employed at the long-term care facilities. And then 79% stated that they never received training regarding the 5 risk factors that contribute to foodborne illnesses. And the 5 risk factors include unapproved sources, improper cooking, poor personal hygiene and employee health, improper holding, and then contaminated equipment and utensils. In regards to the food safety training requirements during the nursing assisted program, 50% of the respondents indicated that food safety training was not provided, while another 38% specified oral training was received from the instructor. And then lastly, 13% responded that they did receive some kind of food handler certification while they were going through their nursing assistant program. Certified nursing assistants were also surveyed regarding their knowledge on personal hygiene practices, and 100% of respondents confirmed that bare hand contact was never allowed while handling ready-to-eat foods. And then another 100% did utilize soap when they were hand washing or doing their washing of their hands during their interactions with the residents. 86% stated that they only use hand soap, no hand sanitizer was used following when they were conducting their hand washing procedure. And then lastly, 14% did use hand soap, follow up with the hand sanitizer during the hand washing procedure. So the major conclusions of the study was that food safety training, if available, was very limited during the certified nursing program and while employed at the long-term care facilities. In addition, the respondents were not trained regarding 5 risk factors that contribute to foodborne illnesses. However, they did receive training regarding the proper hand washing procedures during the infection control section, how to assist the residents in their feeding and hydration while at the long-term care facilities, and they were aware that bare hand contact with ready-to-eat foods was not allowed. Now let's discuss the recommendations. So the results of the survey showed that certified nurses assistants received some level of food safety training. However, the level of training they received is variable from various training programs and long-term care facilities that they were working in. Therefore, requiring a standardized food safety training program is essential to prevent foodborne illnesses among the long-term care facilities. And the following components are recommendations. So the implementation of a standardized food safety program, providing food safety training for certified nursing assistants regarding their assigned job duties, inclusion of training regarding the 5 risk factors incorporated into the certified nursing assistant curriculum, development of partnerships between District 31's local health department and the long-term care facilities in the county, as well as food safety outreach via blogs or newsletters in which the certified nursing assistants sign up for and they receive maybe monthly or quarterly information pertaining to food safety. So that concludes the presentation. I do want to thank the IFPTI instructors and staff, as well as my mentor, Doug Saunders, and of course, my cohort fellows, Cohort 9. And I also like to thank the participating nursing homes and their certified nursing assistants, and Deanna Crosby from Cobb and Douglas Public Health Epidemiology Department. And then lastly, I want to thank my Cobb and Douglas Health staff and members. I couldn't have done this without you guys. And next, I will open it up for any questions.
Okay, thank you, Sharia. So go ahead and type your questions into the Q&A box. Yeah, I see a question already. Sharia, did you provide any CNA training programs with these results and recommendations? And what was their, if so, what was the reaction?
So no, this information has not been provided to the long-term care facilities yet. The surveys were kind of anonymous. So I will be working on providing them with this information to see what we can work on to eliminate any kind of food or reduce the foodborne illnesses that occur in these facilities. So not yet.
All right, another question. During your presentation, you mentioned there were 54 long-term care facilities in Cobb County and 7 in Douglas County. But you also mentioned there were only 54 facilities included in the dissemination of your surveys. rather than 61. Can you explain what happened there?
Yes, so some of the facilities were excluded from the survey because they were considered personal care homes, and the personal care homes are not required to employ certified nursing assistants. So these facilities didn't have any on site. So that's why they were excluded.
Okay, another question. You recommended that food safety training should be provided to CNAs regarding their assigned job duties. Who would be responsible for training them while they are employed at a long-term care facility?
Well, primarily, if their responsibility is assisting in hydration and feeding of the residents, then the certified food safety manager over the food service will be responsible for training the certified nursing assistants to ensure that food safety is held to the highest standard in their facilities.
And kind of a similar question to that, should it be the county that requires food safety training, or should the long-term care facility require the training, or should the accreditation body require the training?
Well, initially, we wanted to start at the beginning, so the accreditation should be providing them some kind of food safety training into their curriculum. And then once they're employed at the long-term care facility, depending on what their responsibility is, if they are having responsibilities in food service, then they would need to have some kind of training. It doesn't have to be a formal training, but maybe just a monthly meeting or a quarterly meeting just to go over the basics to prevent any kind of foodborne illnesses or just any kind of risk factors that can lead to a foodborne illness in their facility.
Okay. And a few more questions coming in here, Sharia. Are there environmental health specialists in Cobb and Douglas counties that are dedicated to just long-term care facilities, or do they do other food service inspections as well?
So in our district, we are responsible for doing all kind of food service. So nobody is just doing long-term care facilities. You're doing restaurants, hospitals, long-term care facilities, schools. So you get a mixture of all of the food service.
That's pretty typical of an environmental health specialist, right?
Yes.
Okay. Here's a question from someone. What kinds of limitations did you encounter while conducting your research?
So there was quite a bit of limitations due to COVID-19. I'm sorry, my light's going up. The long-term care facilities were closed to any kind of visitors. So they weren't accepting anybody coming in. And then when we called to collect information, the manager or the person in charge wasn't in. So just trying to get them to correspond back to us was kind of challenging. But definitely the COVID-19 and then not having any kind of visitation kind of was a limitation for this project.
And I think you'll probably see that throughout the projects for 2020, that really did have an impact. Here's another question for you, Sharia. What action steps do you plan to take with your agency as a result of your study?
So as a result, we do want to incorporate and make sure that the certified nursing assistants are receiving some kind of food safety training. So hopefully we do have a blog that we do provide information to our operators. So maybe start incorporating food safety targeted to these long-term care facilities would be something that we would try in the future.
Great. Okay. I don't know if this is a question here. I'll just read it here, so bear with me. It's a interesting presentation, and I thought so too. Great job. Something to consider when outbreaks happen. Traditionally, food safety is focused on kitchen staff. So they want to thank you for taking this other approach to looking at food safety. And that it was a good idea, Sharia. I agree with that. So I think that's it for your questions. So Sharia, thank you very much for your presentation today.
Thank you.
Okay, well, we'll move on now to the next presenter. And Israel, I believe you're next. So if you want to take control.
Sure. Thank you, Jerry. Can you see my screen?
Yep.
All right. Thanks again, Jerry. So it is my pleasure to be here and share my research project. My name is Israel Warbin, and I'm a Consumer Safety Officer with the U.S. Food and Drug Administration. Today, I present the impact of the COVID-19 pandemic on food safety in the U.S. With the current pandemic going on, it made me think about the food safety system in the U.S. The U.S. had not faced this pandemic in approximately 100 years, and when it did, the food safety system was nothing compared to what it is now. Currently, our food safety system involves regulatory agencies, academia, and manufacturing facilities, to name a few. Prior to the pandemic, inspections of food facilities were conducted on a routine basis by federal, state, local, tribal, and territorial agencies. Outbreaks were investigated with all available resources, and recalls, including recall audit checks, were conducted to ensure recalled foods were removed from commerce. At the time of my research, the pandemic demonstrated new challenges with food safety, especially with performing inspections. Protecting staff from contracting a deadly virus became the primary concern, and travel restrictions were initiated to limit the spread of the virus. That takes me to my problem statement. The effects of the COVID-19 pandemic has had on food safety in the U.S. as facilities regulated by the FDA and USDA are known. These are my three research questions. 1, how were food safety inspections conducted by the FDA and USDA affected during the pandemic? 2, what was the FDA and USDA doing to ensure food safety during the pandemic? And 3, how were the number of recalls, investigations of foodborne illness outbreaks, and food safety violations affected during the pandemic? I have seen inspectional, recall, and foodborne illness outbreak data from my research project. Inspectional data consisted of the number of inspections and classification of inspection outcomes. The data was evaluated and compared between before and during the COVID-19 pandemic timeframes. The study population consisted of data from the U.S. Food and Drug Administration, the U.S. Department of Agriculture, and the Centers for Disease Control and Prevention. These federal agencies were chosen since they are responsible for food safety at the federal level in the U.S. Here, I'm comparing the number of inspections that were conducted in 2019 and 2020 by FDA. In 2019, which is represented by the blue line, there were approximately 7,700 inspections from March through December. The red line is for 2020. As you can see, there was a dramatic reduction in inspections when the pandemic began. In 2020, there were approximately 1,600 inspections conducted from March through December, which was a reduction of approximately 6,100 inspections during 2020. The inspections during 2019 included domestic and foreign inspections, which consisted of routine, mission critical, and for cause inspections. However, during 2020, only mission critical and for cause inspections were conducted. And in addition, no foreign inspections were conducted during 2020. This graph demonstrates the FDA classification outcomes of the inspections that occurred in 2019 and 2020. FDA classifies inspection outcomes as official action indicated, OAI, which means regulatory and/or administrative actions were recommended, or voluntary action indicated, VAI, which means objectable conditions or practices were found, but the agency did not take or recommend any administrative or regulatory action, or no action indicated, NAI, which means no objectable conditions or practices were found during the inspection, or the objectable conditions found do not justify further regulatory action. In 2019, the FDA classified approximately 200 inspections as OAI and approximately 3,000 inspections as VAI, with the remainder as NAI. In 2020, the FDA classified approximately 40 inspections as OAI and approximately 720 inspections as VAI, with the remainder as NAI. Now for the USDA. Here I have the number of inspections that were conducted by USDA for the second quarter, which consists of January through March, the third quarter, which is April through June, and the fourth quarter, which is July through September, for 2019 and 2020. As you can see, during the second quarter in 2020, the USDA was still operating pre and during the beginning of the pandemic, but the third quarter in 2020, inspections decreased, and for the fourth quarter in 2020, inspections increased. Approximately 5,257,000 inspections were conducted in 2019, and approximately 5,313,300 inspections were conducted in 2020. This graph demonstrates the noncompliances documented for the inspections performed during 2019 and 2020 by the USDA. In 2019, the USDA had approximately 80,500 noncompliances, and in 2020, there were approximately 72,600 noncompliances documented. As for the number of recalls that were handled by the FDA and USDA, in 2019, the FDA reported approximately 260 recalls, and the USDA reported approximately 126 recalls. In 2020, the FDA reported approximately 383 recalls, and the USDA reported 31 recalls. Here I have the outbreaks that were investigated by the CDC and FDA and/or USDA. In 2019, there were a total of 17 investigations, and in 2020, there were a total of 10 investigations. In conclusion, during the pandemic, USDA inspections decreased, but the USDA was able to resume and increase inspections during the pandemic by increasing workforce and shifting personnel around to handle the increased production demand. The overall number of inspections performed by FDA, as well as investigations conducted by the USDA, FDA, and CDC, decreased in the pandemic until procedures and personal protective equipment were available to staff. No foreign inspections were conducted by FDA. This was due to both the safety of personnel and travel bans. While the FDA inspections were reduced, the FDA did work with industry to ensure foods were produced safely. For example, the FDA and the Occupational Safety and Health Administration, OSHA, provided a checklist for FDA-regulated human and animal food operations to use when assessing safe operations during the COVID-19 pandemic, especially when restarting operations after shutdown or when reassessing operations because of changes due to the COVID-19 pandemic. The FDA also initiated the new era of Smarter Food Safety Blueprint during the pandemic. However, without resuming routine inspections due to the ongoing pandemic, determining if there is a correlation between food safety issues and the lack of inspections during the pandemic was not possible. Based on the data collected and the conclusions reached through the analysis of that data, the following recommendations are made. 1, the FDA and USDA should consider developing alternative ways of conducting inspections and investigations to regulate food safety during the pandemic while still protecting employees. 2, the FDA and USDA should develop guidance for regulatory partners for conducting inspections and investigations during the pandemic. 3, the FDA should continue to usher in the new era of Smarter Food Safety Blueprint so manufacturing facilities may adapt to food safety culture within their facility, thus decreasing reliance on regulatory inspections to drive motivation to assure food safety. And 4, more research is needed to determine if there is a correlation between lack of inspections and the number of recalls. In addition, more research is also needed to determine if foodborne illnesses were underreported during the pandemic affecting outbreak investigations. And finally, I would like to acknowledge and sincerely thank my director, Ellen Buchanan, for encouraging me to apply and for providing me the support to be able to participate in the IFPTI Fellowship Program Cohort 9. I would also like to thank Doug Saunders, who was an amazing mentor with a tremendous amount of knowledge. In addition, I would like to acknowledge the other IFPTI mentors and staff for their assistance and commitment to the fellowship program. This acknowledgement would not be complete without recognizing the other fellows for their hard work and dedication to public health. Lastly, I would like to acknowledge IFPTI for providing me with this wonderful opportunity. And now for questions.
Okay, Israel, thank you very much. So, audience, feel free to type some questions in for Israel. And someone has typed one already. Israel, why do you think that outbreaks went down in 2020?
And to be honest with you, when I was looking at the data, I'm not sure if the outbreaks went down. They were just maybe slow to respond to them due to the safety of the personnel. And I think once the personal protective equipment was available and policies were put out, I think outbreaks were investigated again. I really don't think it was a reduction, but again, I can't say 100% without, since the pandemic is still current, to see if there's a correlation again between the inspections and outbreaks as well.
Okay. And here's a question. It says, how many of the FDA inspections each quarter were conducted by state inspectors under contract? And did you look into that?
And that's a good question. I did not look into that. When I looked at that data, I was looking at all inspections that was reported by FDA, and this was reported on their website. So I'm not sure if that included state contracts or if it was only FDA inspections. So I do not have an answer for that.
Okay. And another question has to do with imports. Did you look at the activity around imports and whether that went up or down during your study?
So that's something that wasn't part of my research project either. I thought about it, looking at imports. Imports still continue to operate within the FDA, but I did not look at the numbers for imports.
Okay. And a question about new era for smarter food safety. Are there some examples of things that would fall under that project that may have helped during the pandemic?
So the new era for smarter food safety blueprint, it pretty much outlines the partnership between government, industry, and the public health advocates based on a commitment to further modernize the approach to food safety. So again, the new era of smarter food safety blueprint is an approach that leverages technology and other modern tools to create a more digital, traceable, and safer food system. So pretty much the blueprint is centered around 4 core elements, which are tech-enabled traceability, smarter tools and approaches for prevention and outbreak response, new business models and retail modernization, and food safety culture. So this was actually put out during the pandemic. It was intended to be put out before the pandemic, but it was delayed. But then when the pandemic happened, it was a great opportunity to put it out, and that's what FDA decided, and what Frank Yanis did as well. And just during number 4, which is a big one, it's a food safety culture within manufacturing facilities. And I think that was the key, to work with our manufacturing facilities and our industry partners to get cooperation into the food safety itself. But I have no other examples.
Okay, that's good. Okay, so another question here, Israel. Did your research include, or did you see any statistics about employee resignations or employees being laid off? Did that have any impact?
And is that, I'm not sure if he's referring to FDA employees or to employees in manufacturing?
Well, I guess I took it the same way you did, and maybe FDA, but maybe they're asking about employees of, and certainly when you think about it, employees of food manufacturing facilities, for example, or meat plants. If employees there were impacted, you would think that would also be one factor to consider, right? But any thoughts on that?
I see there's a follow-up to it. It says that for employees performing inspections.
There you go. Oh, for employees performing inspections.
So, I mean, personally, the people that I know, there was no resignation. FDA-wide, I'm not sure. But with the inspectors, investigators for FDA, they were responsible for doing some other work, what we call OAI, verifying our firm inventory. So they were still kept on employed, and they were still busy doing other work for FDA. Maybe not doing inspections, except for the for cause or critical and mission inspections. But I'm not aware. But that's something I can look into if you like, to see if there's any, if our workforce was affected by the pandemic itself.
That's a good point about, inspectors did keep busy even though they weren't out doing inspections, right? I know a lot of people caught up on their training during that time period. Oh, yeah. Okay, well, Israel, I think that's the last question I see on the screen. So thank you very much today for your presentation.
Thank you. Have a good day.
Thank you. Okay, well, we have one more to go, and that is Sion. So Sion, if you'd like to take control.
Good afternoon. I am Sion Smith, an environmental specialist with the Fairfax County Health Department. Next slide, please. And next slide. Today, we will discuss retail food establishment virtual training inspections protocol efficacy in Fairfax Health District, Virginia. Next slide, please. Fairfax Health District is located outside of Washington, D.C., serving a population of approximately 1.2 million residents. We are a part of the Northern Virginia region, which includes Alexandria, Arlington, Fairfax, Loudoun, and Prince William Health Districts. Of note for this presentation on virtual inspections, 96% of the population has internet access. Next slide, please. As some or many of you may have experienced, COVID-19 changed the way retail food establishment inspections had to be conducted in 2020 and part of 2021. In Virginia, Governor Ralph Northam declared a state of emergency on March 12, 2020, and issued multiple executive orders to contain the spread of virus and mitigate its impact within Virginia. Virginia Department of Health, or VDH, who administers the food code, waived routine regulatory inspections and approved a provision for virtual inspections during the state of emergency. Early virtual inspections focused on the governor's executive orders, such as proper social distancing and enhanced cleaning procedures, and were completed on the phone. VDH released Enhanced Virtual Training Inspection, or EVTI, in August 2021. These inspections mirrored the contents of a standard risk factor assessment and were completed using video calls by standardized environmental health specialists. Next slide, please. The inspection delivery method differs between standard on-site inspections and virtual inspections. However, they both serve a common purpose of monitoring for compliance with food safety requirements and providing food safety training and education to food operators. Virtual inspections were not conducted in Virginia prior to the pandemic, which leads us to the problem statement. Next slide, please. No descriptive or quantitative data exist regarding efficacy of EVTIs used in assessing retail food establishments within Fairfax Health District in Virginia. The following research questions were assessed to evaluate the efficacy of EVTIs. Next slide, please. What metrics would be helpful in determining effectiveness of EVTIs? What do preliminary compliance data show regarding the effectiveness of EVTIs? What lessons were learned from conducting EVTIs during a public health emergency? The following methodology was used to examine these research questions. Next slide, please. An electronic survey with 10 questions were distributed to Northern Virginia health districts in December 2020. The survey closed in January 2021, with 3 out of 5 health districts providing a response. Survey questions assessing the time it took to complete a virtual inspection was used to examine inspection performance among inspectors compared to standard on-site inspections. There were survey questions that assessed an inspector's ability to observe risk factors during an inspection. Inspectors also shared their experiences and lessons learned from conducting virtual inspections. In addition to the survey, preliminary analysis of risk factors was completed using EVTI compliance data from the Fairfax Health District. There were 108 routine EVTIs completed during the study period. This data was compared to the baseline constructed from the risk factor study that was last completed in 2016 to meet voluntary retail regulatory program standard 9 requirements. Next slide, please. The study population was Northern Virginia health districts that conducted EVTIs in 2020. Next slide, please. Moving on to the results, 75% of survey respondents were able to make contact with the person in charge or PIC for an inspection within 3 days. 87% of the respondents were able to complete the inspection within 2 hours. For comparison, in the Fairfax Health District, all 9,048 inspections were completed on time in 2019, with 20 full-time and 8 part-time standardized DHSs. 7,813 inspections were completed in 2020, with 5 full-time and 1 part-time standardized DHS. Staffing ratios at other Northern Virginia health districts are unknown, but the time needed to complete a virtual inspection was similar to what was experienced in Fairfax Health District. Next slide, please. Compliance data collected from EVTIs conducted in Fairfax Health District were analyzed to complete a preliminary analysis regarding effectiveness of EVTIs. Among the 108 routine EVTIs completed during the study period, compliance with proper cook temperature requirements was comparable to the baseline risk factor data at 100% compliance. Decreases in compliance with safe food source, proper holding, clean equipment and cross-contamination prevention, and good personal hygiene requirements were observed compared to the baseline. The largest decrease was seen in good personal hygiene requirements at a 6% decrease. Next slide, please. Northern Virginia health districts were surveyed to determine whether EVTIs were an effective tool for assessing foodborne illness risk factors. 62.5% of the respondents found good hygienic practices, and 50% of the respondents found clean equipment and cross-contamination prevention somewhat difficult to assess using EVTIs. Approved food source at 87.5%, adequate cook temperature at 75%, and proper holding at 75% were easy to assess using EVTIs according to the respondents. Next slide, please. Lessons learned from conducting EVTI during a public health emergency were as follows. The things that worked pretty well were explaining the inspection process and asking for documentation prior to inspection, and using multiple modes of communication. Some of the feedback that was received in the field was that most PICs were engaged during the inspection and the outreach was appreciated, especially during this difficult time. And some of the food operators even were thankful for the opportunity to learn how to truly self-audit and be able to improve food safety skills at their facility. Areas that could be improved were connectivity issues, having to make multiple calls to reach a PIC, access to interpreters, ability to see the whole picture, and difficulty in carrying on a conversation in certain kitchen environments. Next slide, please. To go on to conclusions, study results indicate inspections can be completed on time by a virtual delivery, but there may be some process improvements needed to ensure all inspections can be completed on time. 25% of the respondents were able to make contact with the PIC within a week, and 13% of the respondents took multiple calls to complete a virtual inspection. Further process improvements could help improve the time it takes to conduct a virtual inspection. Preliminary compliance data and survey responses show that EVTIs are capable of capturing food safety violations. A slight decrease in compliance was observed using EVTIs compared to the baseline, but there may be contributing factors associated with the pandemic that affected food safety performance among this cohort of retail food establishments. Food establishments had to navigate operating a business with limited staff, new health and safety mandates, and other challenges during uncertain economic times. Those factors could have had an impact on inspection performance. Another reason for the observed decrease in compliance could be that violations that do occur are more readily observable during virtual inspections. One of the concerns with virtual inspections is the ability to observe everything. However, initial compliance data show that risk factor violations were observed and documented. Next slide, please. The following recommendations are offered to inform continuous process improvements for virtual inspections. Gather lessons learned from staff who are continuing to conduct EVTIs to inform continuous process improvement. Conduct additional research to determine the efficacy of virtual inspections in maintaining long-term compliance with food safety requirements. Consider routinely using EVTIs in retail food establishments that practice active managerial control and then completing certain types of follow-up visits post-pandemic. That is all I have today, and I would like to thank many people who have made this project possible. Next slide, please. I would like to thank my IFPTI mentor, Brian Collins, our environmental health leadership at the Fairfax County Health Department for their coaching and guidance. I would also like to thank Brian Nash, and my colleagues at Loudoun, Arlington, Fairfax Health Districts, Suja Warrior, Kevin Chrysler, Shannon McKeown, our administrators at VDH, Joe Corby for helping me get this project off the ground, and our instructors, Kathy Fetter, Doug Saunders, Jerry Washsala, and Craig Camel, and Cohort 9 fellows for their feedback throughout the process. Are there any questions today?
Okay, thank you very much, Sion. A really interesting presentation. I'm sure we've got some questions coming in. So one question, Sion, is can you give some examples of how to evaluate time temperature requirements during a virtual inspection?
I'm sorry, Jerry. The sound was muted for some reason, so I did not hear your question.
Okay. So the question again is, can you give some examples of how to evaluate time temperature requirements virtually?
Time and temperature requirements. So we made sure that all the facilities had a checklist so they knew what to expect during an inspection. And one of the required items was to have either a digital or regular STEM probe temperature thermometer. And so whenever temperature was taken, the phone or whatever device was being used for the inspection would have to focus in on the temperature reading to show what the temperature was. Does that answer the question?
Okay, yeah, thank you. You did break up just for a second there. Okay, and then Sion, another question. You picked 5 health districts to survey rather than the whole state. What was your thinking behind that?
5, the Northern Virginia health districts, which are the 5 that I included in the study, were chosen because we share similar demographics, similar challenges. Majority of the population has access to internet, which can be challenging in other ways in other areas. However, with 96% accessibility, did not think that that would have been an issue in our area. So that is how the Northern Virginia region was selected. However, if there were to be a follow-up study, yes, it would be very interesting to see how what the rest of the state's experiences were during this time period.
Great, thank you. And then another question, and I know you talked about this, can you elaborate a little more about the role for virtual inspections after the pandemic, when normal on-site inspections occur?
So definitely our administrators at the Virginia Department of Health would have to provide further guidance as to whether this is something that will remain with us as a tool in the future. But from my limited perspective, I would say that there is a role for virtual inspections in highly performing facilities that practice active managerial control. At Fairfax Health District, we have an active managerial control program where certain facilities are assessed and certified as having these practices. And for those facilities, this might be a good tool to be able to continue to monitor those facilities and assist with training. In terms of follow-ups, there are certain type of follow-ups that could be done virtually. If there was a major issue, if there was an issue of embargo or closure, of course, you would have to go in person. But some of the other things like checking to make sure that a menu has the consumer advisory, checking to make sure that someone has their shellfish tags properly documented and organized, those things might be able to be done virtually. So those were some thoughts.
Okay. And then maybe I have one question, Sian. I'm not seeing any others come in, but one question I have is, I know you focused on Virginia and virtual inspections. And have you heard, did most jurisdictions around the country use virtual inspections? Do you know? And you may not know, but so in other states, do you know if that was pretty standard for people to turn to a virtual approach.
I've heard that South Carolina did some virtual inspections. Sharia was able to give me some information on what they were doing there. Not South Carolina, but Georgia. And also, even within Virginia, the Virginia VDACs, the Virginia Agricultural Department, also did virtual inspections. So it wasn't just the Department of Health that had to embark on this journey during this very difficult time.
Great. Well, thank you very much, Sion, for your presentation.
Thank you for your time.
Thank you. Okay, well, that brings us to the end. Thank you all today, all the participants, for attending this session. And as a reminder, AFTO will post these webinars and the slides on its website. And you can also find those on IFPTI's website as well, along with the papers for the fellows. And I'd like to thank our fellows today. I think they all did a great job. I hope you can join us for the next presentation. So watch your emails for the calendar dates for all the 2 upcoming presentations for the other fellowship presentations. And remember to register and get on those sessions as well, and watch the AFTO e-news for that as well. And again, I'd like to thank AFTO for hosting the fellow presentations today and for the ones that are coming up. And with that, we'll conclude today's session. So we hope to see you on the next presentation. Thank you all for being with us today.